Got it. शेअर होत आहे. तिथं मला जायला कुठे
स्टार्ट करूया.
लहान का पाहिजे ते. नाही पाहिजे मला मागचा व्हिडिओ दिसायला पाहिजे.
नाही ते स्क्रीन शेअर झालं आहे ना.
ओके. झालं की नाही स्क्रीन शेअरिंग चालू आहे. लहान पाहिजे.
स्क्रीन शेअर चालू आहे. चालू करा व्हिडिओ चालू.
Yes, sir.
स्क्रीन शेअर वरनं होत नसेल तर व्हिडिओ डायरेक्ट ऑन करून शेअर व्हिडिओ करा.
Yes, sir. आत्ताचा व्हिडिओ दिसतोय ना सर?
नाही दिसत आहे. आता हे बंद कर, स्क्रीन शेअरिंग स्टॉप कर.
स्टॉप स्क्रीन
आणि शेअर कर आणि व्हिडिओ शेअर कर. आता दिसतोय.
कमी कसं
तुम्ही इथनं पण एक बघू शकता.
हा हे एवढं ठीक आहे. This was well dilated grade 3 NS nuclear cataract. I started with CCC. CCC's size was 4.5 mm at the end. Okay. After this, I have attempted for hydrodissection.
Okay.
Repeated the hydro on other side. Here retroglow wave was not seen. So
but it's a dense cataract, so you cannot see the wave. You have to look for the anterior movement of the nucleus.
Nucleus was tapped back after every attempt of hydrodissection. And I'll put the visco and try to rotate. It is not freely rotating yet.
Now it's rotating.
Now it's rotating on forceful attempt. It's started rotating. Now I start my pre-phaco.
You are planning chopping here.
Yes, sir. Half trench and chop I was planning.
Next part of the video.
Yes, sir. I'll share it. It's seen, sir.
No, you have to stop screen sharing. Don't share the screen. So start the video and then share the video. No, again you are screen sharing. First, you have opened the video, right?
Okay.
And now share share the VLC player, not the screen.
Yes, sir.
Now we can see.
Yes.
Okay. 9:22.
This nucleus is already tilting.
Yes, sir. This is.
So you tried chopping or you didn't try chopping?
I tried chopping, sir.
That part of the video is not there.
41. ये झूमर का.
Okay, fine. You can leave this video. I think basically it must have happened during hydrodissection only because there was no other this thing was made. So this can be pre-existing probably weakness in the posterior capsule. And with the dense nucleus, you have to be very careful with hydro. So when you are pushing fluid, basically the main incision should be pressed. Like posterior lip should be pressed always. Otherwise, even if fluid collects inside and if there is a corticocapsular adhesion, then that gets trapped and it will cause rupture of the posterior capsule. So that's why in dense cataracts, the hydrodissection should not be like the usual forceful hydrodissection. It should be very limited fluid should be used. So that was the most probable cause in this case. And in fact, if after a couple of attempts, if the nucleus is not rotating, you can go ahead with a trench or maybe chop also. And after that, most of the times it starts rotating. But if it has not rotated by then you can again attempt hydrodissection. So for these kind of dense cataracts, it's better to avoid any forceful hydrodissection.
Yes, sir.
Second case you wanted to show?
Zoom की window open है. I'm not able to open Zoom window, sir.
Fine.
Only I can see your photo, but if I press on Zoom sign, I'm not able to open it. नहीं वो भी ये यहाँ पे यही विंडो ओपन नहीं हो रहा.
जूम का विंडो नहीं आ रही.
आ गया बता लो.
శుభం సామంతులు శుభం సంతకం చదివిన ఉంటుంది.
Okay.
Are you sharing?
Yes, sir.
Yeah, go ahead.
In this video, I want to show. I'll start with the beginning. There was fluid behind the posterior capsule. It was clearly seen in this case. This case went for some 25 minutes. It was hard cataract. Chop method was done. Unfortunately, it's 2D video. It's not very clear now, but during cortical wash, we can see there is a fluid in between anterior vitreous phase and the posterior capsule.
Okay, so many times what you can notice is the bulging of the posterior capsule, or even you can see fine particles of the nucleus which have or cortic which are there behind the posterior capsule in the Berger space. So it is important to notice it during the last piece emulsification, because that is the time when this kind of fluid behind the posterior capsule can cause a PC rupture. Another thing which I think the side incision is little bit far away. So I might say that it should be, you can see the mouse.
Yes, sir.
Yeah, it should be somewhere here.
No, I can't see the mouse.
Can't see, just one second. Yeah, you can pause it.
Yes.
So it should be somewhere here.
No, sir, can't see
Like
the
this. Now.
yes, sir.
So if it is far away, basically, if you can see the mouse here.
Yes, sir.
Yeah, if you
I
can,
will see
if
now.
it is little bit away from the main incision, then what happens, this angle becomes little bit uncomfortable. And sometimes when you are doing the either train divide or chopping, this can cause undue pressure on this part of the nucleus or back, and can cause tilting of the lens to that side and can cause dialysis. So I think 90 to 100 degrees is the right angle between the main incision and side.
Yes, sir.
Yeah. Okay, next case you can show.
In the last part, that PC is coming up is seen. Yes. Here the posterior flap of the cortex is above, like in center part, it is.
It's important to be aware of this thing which can happen at the end of the surgery, so that you don't create complications. So once you see it, you just have to be more watchful, either doing the last PC emulsification or last piece, or during cortex removal.
Okay, sir. This is intumescent cataract. So first cruciate incision was taken and fluid cortex was aspirated.
Right. What OVD was used for this case?
Hylocoat was used for flattening the capsule.
Okay. So this removing the cortical matter from both sides is important, not just from one side. Sometimes if you remove only from the main incision or one side incision, the remaining part still there is fluid pocket which is left. So as you showed here, from both sides you removed, right? That is right.
From both sides was done, but I can still see some fluid vacuoles.
Yeah, correct. So for that, what did you do?
We have started first, and this was my initial intumescent cataract. I was not so observant to clear all the fluid vacuoles.
Yeah, so what you should have done is peripheral stroking, which we do with the visco cannula. So you milk the cortical fluid from all 360-degree towards center. So that flattens the anterior capsule completely. Once that is done, it's like a routine lens. So, and generally with these cases, once you aspirate, I think better to use the forceps, because sometimes in fact the capsule becomes concave because you have removed a lot of fluid underneath. So once it becomes concave, it's a little bit difficult to use the cystitome. So because the support may not be there. So in that case, I think better, like here you can use the micro forceps. So this is better.
Even with the capsular forceps, it's running out.
Because of you did not remove those fluid pockets, so that's why in the initial part of removing fluid, you have to be more thorough, so you don't get this complication. So what did you do now?
But I tried to do quick pull technique, but still it was outside for the 1 or 2 clock hours. Then it came in.
Okay. So you approach from the side incision for the quick pull?
On the right side port.
Yeah. So basically in quick pull, you have to be really quick. So if you are slow, that means it is going to extend for, more arc. So like here, you have to quickly pull it inside. The speed is, so it has to be like a jerk. Yeah, correct. Short jerks and it brings it in quickly.
But still it is outside on this, it's not coming.
Yeah, so you need to pull it very quickly and fast. Then it comes in, because it's very rare to have this Capsulorhexis going behind. It usually stops in the zonular area.
Okay.
The hesitation is the main cause of this problem. Like if you are hesitating to pull it quickly in, then it is going to extend more arc towards the zonular area. Yeah, right now, see, once you quickly pull it in, it always comes in. The hesitation and slow pull is the issue.
Yes, sir.
Yeah, fine. I think now it has come in.
There is one more similar video like this. This
So
is
intumescent one.
intumescent cataract.
And for intumisons, always look at the age of the patient. Younger the patient, usually you have to be more careful
Yes, sir.
because the zonules are more elastic, capsule is elastic, and the chances of extending is more. This is perfect. You can see the fluid getting aspirated.
Yes, sir.
You are using the side port incision.
Yes, sir.
So that's perfect. So if you use main incision, sometimes it itself causes extension. So I have seen sometimes surgeons tries to use the main incision. So if you used heavy OVD like Hylucode, then it's fine. You can still use the main incision, but otherwise the side incision is the best way to approach.
Yes.
So you're removed from one side.
I removed it from the other side also, sir.
Right. So just observe the entire lens surface. If there is any fluid pocket, you have to remove that. Another way to use it, yeah, visco. This is correct method. So you pressed it from periphery to the center.
Yes.
And another thing is like when you are doing it on topical. So now you are using both your hands to aspirate. So on topical, another method is that you can attach the aspiration tubing of the phaco also, and you can control it with your foot switch. So you need a connector for that. So of course, on topical, I also do manually only because it's quicker. We don't have to attach it to anything. But if the patient is uncooperative and you want to hold the globe with one hand, then you can use the active aspiration of the machine itself.
The bimanual aspiration can, or the coaxial only we can use.
No. The aspiration tubing, you have to connect with the 27 gauge needle, 27 gauge canal. So you need a connector for that, which is available in our retina sets.
Now I started with cystitome only. But
yeah, I think cystitome should not be used in these cases. No? It's not of, I mean, you can do it, but as I said, the anterior capsule is either it has no support in some areas and there might be some fluid pocket left. So it's better to use the micro forceps. So micro forceps helps because you can go from the side incision rather than the main incision. So again, now it's extending. See, now you have to stop at this point only. You can see it has, you can pause the video a bit.
Yes.
Yeah. So you have to basically see what is the size of the rhexis already. So this is the corneal diameter, right? So you want somewhere around 5 mm. Okay. So if you want 5 mm, then it has to be less than half of it, correct? Okay. So the rhexis should be something like this. Yeah. This should be the size of the rhexis. It's already bigger than that. Okay, so once you have gone already outside the size of the rhexis, it's extending basically. which is many times missed. So you should have stopped before this only and use forceps to start pulling it inside. Okay. Stopping late itself is the cause of complication. Yeah. So now what you do?
With the forceps, I'll try to continue.
Now you should not continue. Now this is the time to pull it centrally only. Okay. Even before it starts going out. So now if you give tangential pull like this, now you have given it, so it is going to go out, which it did. Right? So at this point, you must pull it centrally only. So the thing is, you have to anticipate that it is going to. Now I can, because of I have seen so many cases, and now you should also analyze this. I can anticipate what is going wrong even before you start doing it. Correct.
Yes.
So first important part was size of the rexis, already quite bigger. So, and particularly in tumescent cataract, you don't want to cross the 5.5 mm size of the rexis, because it's like closer you go to the zonules, more chance that it will pull it outside.
Yes.
So basically both these cases, both you could have prevented.
Yes, sir.
And while pulling it also, in previous case, as I told, it has to be very quick and jerky pull just centrally. So the extension hardly crosses 1 or 2 kilometers, not more than that. Because if you have a large extension, then what happens if you are putting a foldable IL, sometimes that area, the capsule is not there. So you may have PCL, which is T-centered, or it has come out of the back.
Yes, sir.
But here you could pull it in. So that's what is right. So in if you are prepared well for the case, I think very rarely you get Capsulorhexis which is going to the posterior capsule in such cases. Very, very rare.
Okay.
Yeah, now also I think you should go ahead with the forceps only. Okay. Cystotomy is good when the anterior capsule is convex and there is no intumescence.
Yes.
If it is concave, like even in Morganian cataract, if the capsule is not proper, there is no support, then cystotomy is, you can do it, but it's very awkward to complete it and you don't have a proper control.
Yes, sir.
So just you have to continue with the microforceps.
Yes, sir.
Okay, so this was, I think, well rescued after the initial outward extension.
Yes.
Yeah. So you have any other case to share?
Yes, sir. There was one soft cataract. This was very soft cataract with the central dense PSC. So patient was opting for cataract surgery.
Younger patient?
Younger patient, sir, 48-year-old.
Okay. Such patients you should observe very carefully on the slit lamp also. Or when you take the patient under table, you just watch for the edges of this posterior subcapsular opacity. If they are very sharp, then there is a likelihood of posterior polar. But this looks fuzzy only. I don't know. It's not focused, so I can't say.
So 5 mm rexis was made.
Yeah, this was perfect. Perfect fluid wave.
Hydrodissection was done. Complete wave was seen. Hydrodelineation was also tried.
Okay.
Now, golden ring was seen. Hydrodelineation was also fine.
So basically, golden ring will tell you the hardness grade also. Like if it is a smaller golden ring, then it's softer. If it is a bigger golden ring, then it's likely to be denser.
And sometimes I think if we are not able to get a hydrodelineation, means we are feeling it is soft, but we are not able to get hydrodelineation in spite of multiple.
Then it is not that soft.
So it was freely rotating also. Rotation was tried. And in this case, we attempted carousel technique.
So
Initially,
as I said, so this is a big nucleus. So what were the parameters?
Sir, power was less. It was just 20, and vacuum was 380.
Yeah, and what you did, sorry, perfectly was the position of the probe, which was initially in the mid periphery, and the bevel was towards the nucleus, and then you applied vacuum. So it starts rotating that way, correct? So now the nucleus is separated from the epinucleus part, that you will be phaco aspirating almost. So and power was kept less, so that's good. So only thing you have to be little bit careful about is that if you start doing carousel and it's not getting separated from the epinucleus, then you may have to go back to either chop or train device. So avoid burying the phaco probe deep when you are doing carousel. It has to be superficial only. Yeah, so the air bubbles were little disturbing.
Because there was less power, tip was getting blocked. So
Yeah.
later increase the power, then this quadrant removal of central nucleus part was done. Again decrease the power and then remove the epinucleus.
I think this was perfectly done.
There was one more soft nucleus case in which so there's a soft nucleus. this rexis is 5 mm, but on hydrodissection, there was nucleus prolapse. I was not able to put it back in the bag. Then I tried aspirating it in the anterior chamber only.
This was again soft one.
Soft one.
Yeah. So you started doing emulsification in the prolapsed area.
Yes, sir.
It was soft, so you must have used very little power.
It was 20, 30 around.
Yeah. So once you cut off, like here now you have cut off part of the nucleus, you can rotate it. Rather than trying to do this, trying to remove it from this side, you can just rotate the nucleus to other side like this. You can rotate this nucleus to other side, and then you can start aspirating, because this is little bit awkward sometimes because large part is in the sub incisional area.
I think in this angle is more, so she's finding difficult to
Yeah,
rotate.
again same. I think side port, the side incision, you are keeping it very far from the main incision. It should be at 90 to 100 degrees. So this is almost like 180 degrees.
With the less power, it was centrally, it was denser only.
Yeah, correct. So that's the main issue for carousel or even with the prolapse. If the nucleus is denser, then what you can do is just after removing peripheral part, you can push the nucleus down and start with your regular technique, whether you use range divide or use stop and chop, you can go to that. Otherwise, it becomes like stuck. You're stuck between the two techniques. Here, I think you removed with carousel only. It's like stuck. You did
But it is in
range
the
divide.
anterior chamber only. I had to apply the phaco and remove in parts.
Yeah. Yeah, it's soft only. I think considerably soft. Only thing I think you have kept the power itself quite low, so it's taking time for emulsification. And using OVD in between, whenever you feel the OVD is washed out, you should reapply in such cases. Because if the tip is anterior, you are closer to endothelium, so you have to be little careful. Of course, these are very soft cases, so if you have good control over the power delivery, it doesn't cause any edema or anything.
Now I'll show some videos of IOL implantation complications. So in this case, nucleus management was done, cortex was done. While implanting IOL,
The wound is hydrated.
wound is hydrated. No, this is second time.
Does RYCF lens also become stiff with low temperature?
Generally, not much because it's a hydrophilic. So yes, little bit it will become stiff.
Because yesterday
What do you want to show here?
So here it released outside only.
The lens.
Yes, sir.
Okay. So you are basically the cartridge got out of the incision.
Yes, sir.
So when you are pushing, basically go back. Were you supporting the globe with the left hand? Yeah. So this left hand Sinski, na? Just pause here. So this again, I think that distance between the incision is too much. So that's why it is not able to give the counter traction. For giving counter traction, it has to be like 90 to 100 degrees from the main incision. So then this Sinski will pull the eye towards you or towards the cartridge, and then cartridge you are pushing that injector inside. So it gives the counter traction for the IL insertion. So use of the left hand is very important if you are doing IL insertion. Yeah. So and if you are not using the other hand, like for giving counter traction, then your cartridge, the tip should be inside the incision completely. Right. So basically you can play now. So it got out of the incision. That's why half of the lens is still outside.
Okay.
So here you can like half of it is inside, then you can slowly gradually push in. Only thing you have to be careful about Descemet detachment, because if there is Descemet, it will increase. So the rule generally is that if more than half has gone inside, then you can push it in. But here I think it's little bit touch and go. So that's fine that you pulled it out.
So in
Again,
this case, we can pull it out and...
Yeah, you can reload, and maybe next time I will enlarge the incision little bit so it goes in smoothly, because we don't want the incision tears.
Yes, sir. So this was the first case I was trying under subconjunctival anesthesia. Surgery went fine. I did trench divide technique. Patient was cooperative. And after nucleus management,
What do you want to show?
but it was stuck. Even with the push release technique, then it released.
Double haptic hydrophilics. I think they are by design they are little bit faulty. I think this. If they have a little bit of softer haptics, if they have to have a stiff haptic. So I think the haptics are little thinner or softer, they get stuck. And these plungers also, they have to be non-compressible plungers, the silicone tip. Na? So that plunger also is sometimes cut awkwardly, like at an angle. So they may get stuck in between.
The IOL was not stuck. It was released and I had only loaded this IOL. But and checked outside before injecting also.
So what was stuck? The same thing. Half part went outside.
Yes, sir.
No, what was stuck? You were saying?
Yes, sir. IOL. I'm trying to push, but it is not going.
So basically, if you can see that plastic plunger has pierced into the silicone. So it has reached its, complete push basically.
Okay.
So this was the fault in the injector itself. Otherwise, it was fine. Another thing which can happen is if the cartridge which you have attached to the injector, if it is not completely pressed in, so it is there is a lock. Once you put it in, it gets locked. So if it is not locked, then it is slightly away. So your plunger basically cannot reach or push the IOL completely out. So that could be one of the reasons.
Here I tried multiple times pushing and
because it has reached its end of the movement, that plunger. Plunger cannot go any further now. So most likely the cause is that the cartridge is not locked in the injector. Or it can be just a faulty injector. So finally it went in. Now here, because most of the IOL is inside, now you can just withdraw the cartridge. So the haptic which is outside the eye, you can just push it in.
If IOL will again come stuck in the touch the new cornea and.
Okay.
So one more thing I have observed is in case of like if 5 to 6 mm pupil and we are doing chop method. While doing chop method, most of the times the pupil becomes smaller again or iris starts prolapsing.
Pupil becomes small while
chopping, because the irrigation and both the our phacoprobe goes below the pupillary plane, so pupil becomes again smaller and iris starts prolapsing.
that should not happen because of the chop as such.
In this one case, I'll show some.
Yeah.
If the irrigation is directly toward below the iris or directly against the iris, then it can become slightly floppy.
No, or maybe the pupil itself is smaller. Like in this case, I think pupil itself is
pupil when we start. That in those cases only it happens most of the time.
Yeah, if the pupil is like mid dilated, it is prone for becoming smaller during the procedure.
Again, during cortical wash and IOL, it dilates. But during
Dilates, yes.
top, it becomes smaller.
Hmm.
In
So
this,
basically, what happens is that it dilates because of kind of reverse pupillary block, which happens. So, as Dr. Nidhi was saying, na, if the irrigation is above the iris, there is a reverse pupillary block. So, it itself causes a little bit of dilatation and deepening of the anterior chamber.
okay. In this case also, it's
Yeah, in
prolapsing.
this
and-
case, though, it was small to start with, so it's likely because when you rotate the nucleus, it touches the iris, so it will cause pupillary constriction.
So what we should do in this case, sir? With the adrenaline also, it doesn't differ much in between.
Basically, you have to see whether you can manage with this pupil. Otherwise, you have to put iris retractors.
If there are all well separated 6 pieces, in 4-5 cases it happened. In well separated pieces, I continued.
Yeah. So, if in case it is causing struggle in the further maneuvers, it's better to use iris hooks rather than complicating things.
Yeah. And one more thing is, sir, I'm able to do chop only in the very hard grade of cataract. In grade 2 NS, I start, but chop is not possible. Again, I shift back to trench divide technique only.
For very soft grade like grade 1, grade 0, it's not possible sometimes to chop, but grade 2 onwards, it's okay. So basically, you have to reduce the power, echo power used. And for harder grades, you have to bury more. So softer grades, you can bury less. So you don't have to go very deep inside that. So for softer grade, there is some amount of mechanical chopping which you have to do without actually burying, just between the phaco tip and the Sinski or the chopper, you have to crush it in between. So softer grades, that works.
Okay. I think I should change the parameters and try. And mechanical chopping, I should attempt. For.
Yeah.
In this case also, it was first central plate I have divided. Now here I'm trying for chop technique. Reduce the power to 50. Now I'm shifting again back to trench divide technique.
I think the video is not playing.
Yeah. With the 50 power, I think that nuclear matter is cleared off. So again, I shifted back to trench divide technique.
This was torsional or longitudinal?
That time I was using torsional only.
That's fair enough. Basically, if you your attempts fail, then it's better to shift back to train divide and finish. For softer grades, it will happen more often.
Yes.
But try longitudinal chopping, it is much easier.
Yes, sir.
Only pure longitudinal power for chopping.
Yes, ma'am. With grade 2 NS, power can be 50. Huh?
Means at least you should be able to go inside. If it is only longitudinal, we generally don't go through it. Comes slowly, I feel. Torsional, we just go through and through because it doesn't stop and bury. With longitudinal, there is control. Means even if you keep 70, you will feel that when you have a slight hold and then you stop. But it won't be like a bury in the hard cataract. You just slightly bury it and then mainly use your left instrument to chop it.
Okay.
Next case, I think we can take next time.
Yes.
I will just share an interesting case. So you can watch it. What is the observation in this case?
Peripheral cataract. Huh?
Yeah, so what you can see here, very dense opacity in this area only.
Yes.
Localized. Okay, so such cases, because this is unusual cataract, right? You don't see it in age-related cataract. This is not definitely age-related cataract because there are no cortical spikes anywhere else, just localized opacity. So it can be post-traumatic, like some thorn prick or something has happened. I have seen a couple of cases of kind of posterior polar. That means you see a posterior polar kind of opacity, not in the center, but slightly in the mid periphery. So when I started this case, I realized that there is definitely pre-existing posterior capsular dehiscence here. Okay, you can see it appears little deep also.
Yes, sir.
Yes, sir.
And you can see few kind of, I don't know, the strands or some directional change in this area, which is going towards that area, which we see in posterior polar cataract also sometimes. Okay, so what I did was I did sorry, Capsulorhexis, and then I realized that it's not rotating because it's stuck basically, that that area is stuck. Sorry. So now the idea was that I will just prolapse it out of the bag and aspirate it in the anterior chamber. So I have lifted it up from one pole, which was, so the other pole is not rotating. You can see now it has rotated. Okay. You can see how dense it is only in one side, and there you can see little bit of some kind of central clear area in that opacity. So this looks exactly like posterior polar, but in the peripheral area. This patient gave no history of trauma, but his other eye is operated in childhood and which has very poor vision, so kind of a complicated cataract. And this eye, he is not, he had started having vision problems since 1 year. Till that time, he didn't have any visual problem, but definitely it looks like a posterior polar kind of cataract. For thorn prick, I couldn't see any corneal injury, sorry, injury or opacity as such. So more likely a congenital phenomena rather than. Now just watch. Okay, so I thought that I think it was just adhesion in the periphery or something like that. But by this time you can see these opacities in the vitreous. I noticed it even before when I was emulsifying. I could see few opacities which are there in the anterior part of the vitreous. Somewhere in between, when I was emulsifying, I saw those. So at that point only, I thought there is a PC opened. Yeah, you can see this. Sorry, pause it. This opacity here. My arrow is seen.
Yes, sir.
It's behind the posterior capsule in the anterior vitreous. Okay. You can see that is moving. Okay, and it looks similar to these opacities which are there here.
Yes,
So
sir.
I thought it must have ruptured here, but at this point there was no rupture. But you see now it opened, right? So this whitish thing was the area of weakness, same where it was adherent. So at this point, I could have pushed visco, but I thought there is no problem with the PC. See, this is the area. You can see this fibrous, and from there only it just opened up.
Yes, sir.
Yeah. So there was weakness in that area,
Yes.
and because during the withdrawal of the probe, maybe if I had pushed visco, might have served, but not necessarily, because if I start doing IA at that time also, it can open. So this was the case. Anyway, so I did a vitrectomy and placed the PCIL, 3 PCIL in the sulcus and did optic capture. So in such case, always check that incisions are not leaking. And this was done on topical, so I didn't give any block. Patient was cooperative, not having any discomfort as such. So interesting case. So you have to be, and at the beginning only, I asked the patient whether he had any thorn prick injury or anything like that, because it looked like that. Okay, so interesting case.
So IOL was placed 90-degree away from the in that axis, 90-degree away axis.
It doesn't matter because it's a PC rupture. So the anterior capsule is okay only.
Sulcus.
So these haptics are in the sulcus. Right? Interesting case.
Yes, sir.
Okay, so next time.
Thank you.
Chalo.
Thank you, sir.
Okay.